Positive and Negative Syndrome Scale in Schizophrenia Assessment. Schizophrenia affects approximately 0.3% of the global population, with a lifetime prevalence of 7.2 per 1,000 individuals. Dysregulation of dopaminergic neurotransmission, particularly hyperactivity in mesolimbic D2 receptors and hypoactivity in mesocortical pathways, underlies symptomatology. The Positive and Negative Syndrome Scale, PNSS, is a 30-item structured interview used to quantify symptom severity, with scores ranging from 30 minimal symptoms to 210 maximum severity. First-line treatment includes second-generation antipsychotics such as risperidone 2 to 6 mg/day orally, with PANSS used to monitor response defined as greater than or equal to 20% reduction from baseline. Key points. Note: the Positive and Negative Syndrome Scale, PNSS, consists of 30 items rated on a 7-point scale, 1 equals absent, 7 equals extreme, yielding a total score range of 30 to 210. A greater than or equal to 20% reduction in total PANSS score from baseline is considered a clinically meaningful response to antipsychotic therapy. The PANSS Positive Subscale, 7 items, has a score range of 7 to 49, with scores greater than or equal to 21 indicating moderate to severe positive symptoms. The PANSS Negative Subscale, 7 items, ranges from 7 to 49, and scores greater than or equal to 25 are associated with significant functional impairment. Inter-rater reliability for PANSS is high, with intraclass correlation coefficients, ICC, of 0.89 to 0.94 in trained clinicians. The PANSS General Psychopathology Subscale, 16 items, ranges from 16 to 112 and includes cognitive and affective symptoms. PANSS must be administered by a trained clinician. Untrained administration results in kappa values as low as 0.45 for individual items. A total PANSS score greater than or equal to 70 is typically required for inclusion in clinical trials of antipsychotics. The PANSS-derived Clinical Global Impression Schizophrenia (CGIS) scale correlates with PANSS at R equals 0.78, P less than 0.001. PANSS scores improve by an average of 18.3 points, 95% CI, 16.7 to 19.9, after 6 weeks of treatment with risperidone 4 mg per day in first episode schizophrenia. The PANSS Marder Factor Analysis Model divides symptoms into 5 domains: positive, negative, disorganized, excited, and emotional distress, with internal consistency Cronbach's alpha of 0.81 to 0.89. A PANSS total score reduction of greater than or equal to 30% at 6 weeks predicts remission, Andreasen criteria, with 76% sensitivity and 68% specificity. Overview and epidemiology. Schizophrenia is a chronic, severe neuropsychiatric disorder characterized by disturbances in thought, perception, emotion, and behavior. The International Classification of Diseases, 10th revision, ICD-10, classifies schizophrenia under code F20, with diagnostic criteria requiring at least one of the following core symptoms present most of the time for at least 1 month: delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior, along with significant social or occupational dysfunction. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, requires at least 2 of these symptoms, with at least one being delusions, hallucinations, or disorganized speech, persisting for greater than or equal to 6 months. Globally, the point prevalence of schizophrenia is 0.3%, 95% CI, 0.27 to 0.33, equating to approximately 24 million individuals affected worldwide, according to the World Health Organization, WHO, 2023 estimates. The annual incidence is 1.5 per 10,000 person-years, with regional variation. Incidence is 1.2 per 10,000 in East Asia, 1.8 in North America, and 2.4 in Sub-Saharan Africa. Prevalence is higher in urban areas, 0.41%, compared to rural regions 0.23%, with a relative risk RR of 1.78, 95% CI 1.52 to 2.08, after adjusting for socioeconomic status. Pathophysiology. The pathophysiology of schizophrenia involves complex interactions between genetic vulnerability, neurodevelopmental disruption, and neurotransmitter dysregulation. The dopamine hypothesis remains central. Hyperactivity of mesolimbic D2 receptor signaling is associated with positive symptoms, while hypoactivity in the prefrontal cortex D1 receptors contributes to negative and cognitive symptoms. Post-mortem studies show 10 to 15% increased D2 receptor density in the striatum of untreated patients, with receptor binding potential, BPND, measured via superscript 1c, raclopride PET averaging 3.2, SD equals 0.6, in schizophrenia versus 2.8, SD equals 0.5, in controls. Genetic studies identify over 287 risk loci via genome-wide association studies, GWAS. The strongest association is with the major histocompatibility complex, MHC, locus on chromosome 6p21.3, p equals 5 times 10 superscript 2, implicating immune dysregulation. The C4a gene within this region mediates synaptic pruning, with elevated expression leading to excessive elimination of synapses during adolescence, a period coinciding with symptom onset. Copy number variants, CNVs, at 22q11.2 deletion confer a 25-fold increased risk, RR equals 25, 95% CI, 15 to 40, affecting COMT and PROD genes involved in dopamine and glutamate metabolism. Clinical presentation. The classic presentation of schizophrenia includes positive, negative, and cognitive symptoms. Positive symptoms, present in 85% of first episode patients, include delusions, 78%, hallucinations, 70%, predominantly auditory, disorganized speech, 65%, and grossly disorganized behavior, 50%. Delusions are most commonly persecutory, 60%, followed by referential, 30%, and grandiose, 20%. Auditory hallucinations are experienced as voices commenting, 45%, or conversing, 30%, with 70% reporting 2 or more voices. Negative symptoms occur in 60% of patients and include blunted affect, 55%, alogia, 48%, avolition, 62%, anhedonia, 50%, and asociality, 58%. These are often misattributed to depression or medication side effects but are independent predictors of functional outcome. Cognitive deficits affect 85% of patients, with average IQ reduction of 10 to 15 points from pre-morbid levels. Deficits are most pronounced in working memory, affect size D equals 0.89, attention, D equals 0.85, and executive function, D equals 0.92. Diagnosis. Diagnosis of schizophrenia is clinical, based on DSM-5 or ICD-10 criteria, with the PANSS serving as a validated tool for symptom quantification and treatment monitoring. The diagnostic algorithm begins with a comprehensive psychiatric evaluation, including history from patient and collateral sources, mental status examination, and exclusion of organic causes. Laboratory workup is essential to rule out secondary psychosis. Recommended tests include key points, complete blood count, CBC normal WBC 4.5 to 11.0 times 10/L, anemia, HB less than 13g/DL men, less than 12g/DL women, may mimic fatigue. Comprehensive metabolic panel, CMP Na 135 to 145 millimoles per liter, Ca superscript 2 8.5 to 10.2 mg/dl. Hyponatremia may cause confusion. Thyroid stimulating hormone, TSH reference 0.4 to 4.0 mo/L. Hyperthyroidism can mimic agitation. Urine toxicology screen detects amphetamines, cocaine, cannabis, phencyclidine, false negative rate 15% for synthetic cannabinoids. Management and treatment. Acute psychosis requires rapid stabilization in a safe, low-stimulation environment. Monitoring includes vital signs every 15 to 30 minutes until stable, with continuous pulse oximetry if sedation is used. Agitation with risk of harm is managed with rapid tranquilization. First line is intramuscular, IM, olanzapine 10 mg, which achieves symptom reduction in 20 minutes, mean PNSS decrease 8.2 points at 2 hours. References. 1. Claude AI et al. Efficacy and safety of the muscarinic receptor agonist KarXT, xanomeline trospium, in schizophrenia, Emergent 2, in the USA, results from a randomized, double-blind, placebo-controlled, flexible dose phase 3 trial. Lancet, London, England. 2024, 403, 10422 160-170. PMID, 38104575. https://pubmed.ncbi.nlm.nih.gov/38104575. doi 10.1016/S0140-6736 23 02190-6. 2. Guayana G. et al. Cognitive Behavioral Therapy, Group, for Schizophrenia. The Cochrane Database of Systematic Reviews. 2022, 7 CD 009608. PMID, 358666377, https://pubmed.ncbi.nlm.nih.gov/358666377. DOI 10.1002/1465185.cd009608.pub2. 3. Siskind D. et al. Efficacy and safety of semaglutide versus placebo for people with schizophrenia on clozapine with obesity, Coast of Phase 2, multi-center, participant and investigator blinded, randomized controlled trial in Australia. The Lancet. Psychiatry. 2025, 12, 7493-503. PMID, 40506208, https://pubmed.ncbi.nlm.nih.gov/40506208. doi 10.1016/S2215-0366, 25, 00129-4. 4. Schneider-Thomas et al. Efficacy of clozapine versus second-generation antipsychotics in people with treatment-resistant schizophrenia, a systematic review and individual patient data meta-analysis. The Lancet. Psychiatry. 2025, 12, 4254-265. PMID, 40023172. https://pubmed.ncbi.nlm.nih.gov/40023172. doi 10.1016/S2215-0366, 25, 00001x5. Zhu M.H. et al. Amisulpride augmentation therapy improves cognitive performance and psychopathology in clozapine-resistant treatment-refractory schizophrenia, a 12-week randomized, double-blind, placebo-controlled trial. Military Medical Research. 2022, 9, 159. PMID, 36253804, https://pubmed.ncbi.nlm.nih.gov/362533804. DOI 10.1186/S40779-022-00420-0. 6. Mishra B.R. et al. Comparison of acute followed by maintenance ECT versus clozapine on psychopathology and regional cerebral blood flow in treatment-resistant schizophrenia, a randomized controlled trial. Schizophrenia Bulletin. 2022, 48, 4814-825. PMID, 35556138, https://PubMed. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.